So this was my final culminating project for my master's project. I used our DODD data to look at predictors of pneumonia death in our community because I work for the data warehouse and we have really nice access to lots of data. Maybe we should click. Okay, so here's an outline of what we're going to talk about today. I'm just going to give a brief overview of DODD. We probably all know a lot of it, but this is more detailed things. Then I'm going to talk about what pneumonia is and how pneumonia affects individuals with developmental disability. And then just more about my study population, how I actually did the study and the conclusions that I came up with and the overall impact of the study. So according to DODD, an individual with a developmental disability is somebody that has a mental or physical impairment which began before the age of 22 and is not going to go away on its own. And one way to classify it as not being is that if an individual has a mental or physical impairment which is due to mental illness, that's not considered a developmental disability. So it's something usually individuals are born with. And in 2016, we served 95,955 individuals actively with a developmental disability. And because there are so many different types of disabilities, some examples are cerebral palsy, epilepsy, Down syndrome, Fragile X syndrome, autism, Tourette syndrome. There are a lot of levels of independence and health quality. And that's why the individuals in our system get a lot of different options, particularly with their living arrangement. The main living arrangement that people in this community do is familial living. 75% of our community lives with their family, but they can also live in an intermediate care facility, a developmental center, or through supported living. So supported living, basically, they can choose to live wherever they want, independent usually, or with a roommate. And then care is given as an as-needed basis. So a nurse will come to them whenever it's needed. That's a little different from DCs and ICFs, in which care is 24/7. And those are individuals who have intermediate levels of behavioral or physical health that needs supervision all the time. DCs are state funded and ICFs are usually publicly owned, but they house between 5 and 150 individuals. So that's different than living on your own. And in addition to those unique living arrangements, there's a lot of state funded support programs that individuals make use of. We have 94% of our population using these state funded programs, and they include adult day services, home delivered meals, support community employment, transportation, and the installation of like home adaptability systems. So because there are so many different diagnoses that fall under the umbrella of developmental disability, there's also a large range of the severity and health and the results of that. But most disabilities unfortunately result in poor nutrition and kind of sedentary lifestyles, which increases the onset of secondary conditions like thyroid disease, osteoporosis, cardiovascular disease, and respiratory infections. So because of these disabilities, there's a lot of secondary conditions that also occur. And something that I learned while doing this project that I hadn't realized is that individuals who live with their family or in the community as independently have lower rates of access to primary health care, like cancer screenings or vaccinations, or just those annual checkups we go to. And there's a couple of reasons for that. One of them is that we have a state mandate that an individual, residential care facilities are supposed to offer these services to all their residents on a yearly basis. So every year we have dentists and physicians and nurses going to these facilities and routinely giving a check to all these individuals. And that's not the same for an individual that lives with their parents or their guardian. The parent or guardian has a choice whether to take the individual to a physician. And unfortunately, a lot of these individuals have a fear of hospital settings, or they have special communication needs that make these doctor visits really difficult. So that could be a reason why families choose not to go every year to the doctor, because it's just a big hassle. And the third reason, something that I really hadn't thought about, was that we had a lot of mass deinstitutionalization, which was really great because it left a lot of people going into the community from these institution settings. But there was no big effort made in the education standpoint to educate doctors on how to interact or to take care of these individuals. So I read a lot of reports where it's not just the individual that's not feeling comfortable going to the doctor. A lot of doctors and nurses don't feel that they can provide adequate care or that they're really understanding what their patient needs. So there is this misunderstanding that happens that we haven't been educating the doctors that are expected to work with these individuals. So what is pneumonia? Pneumonia, there's 4 different types depending on where it comes from. So there's bacterial, viral, fungal, and aspiration. And there's this large group of symptoms that usually occur, and depending on which type of pneumonia you have, you see more symptoms more likely. So usually there's a persistent cough, there's fever, shortness of breath, headache, diarrhea. And depending on the type of pneumonia, it's common amongst different populations. The most common for individuals with a developmental disability is aspiration pneumonia, which is caused by accidental inhalation of food, liquid or gas or dust or just any objects. That's the most common in our population. But pneumonia in general is the 3rd most frequent cause of hospitalization in the US, and it's fatal in 15% of cases. Viral is the most common, but it's less severe. So bacterial is more severe than viral, but more individuals get viral. And usually aspiration pneumonia, that's how it begins, and then it develops into bacterial pneumonia. So that's kind of an issue in labeling what kind of pneumonia it is. Do you label it as what it started as or what you ended up with in the end? Diagnosis is usually made by physicians through a physical exam or a chest x-ray, and you identify pus or fluid in the air sacs. Sometimes this can be hard to do by looking at the lungs, but an important key to that is starting treatment early, because the earlier you start the treatment, the less likely that the individual will pass away from it. And the treatment depends on the type of pneumonia you have, but usually there's antibiotic therapy, antifungal, oxygen, decongestions, and breathing exercises. So a combination of those depending on what kind you have. And individuals that have weak immune systems are in particularly susceptible to pneumonia, and that could be individuals who are going through cancer, who have AIDS, who have a developmental disability, a lot of older individuals. Oops. So the good thing is that pneumonia is preventable to a degree. Bacterial and viral pneumonia, particularly, there are vaccines. Bacterial pneumonia is just a once-in-a-lifetime vaccine, and it's usually recommended for children with weak immune systems or the elderly. So when you become 65, you might see commercials on the TV encouraging the elderly to get their pneumonia vaccine. Viral pneumonia is really just the flu shot that they encourage individuals to get every year. That's the main preventer of viral pneumonia. And aspiration pneumonia, there's no vaccine, but that one's kind of just the most straightforward and unfortunate one, because it's a result of choking. So by following an individual's care plan carefully and making sure that they're eating sitting up, or that their food texture, a lot of our individuals have like specific food textures that their food is supposed to be cut up. So it's pretty avoidable, this aspiration pneumonia. And individuals in our community, the ones that like have difficult time swallowing or coughing, or the ones that are bedridden, they're usually the ones more affected by it because they don't have as much control. Usually, even the simple fact that a lot of those individuals are fed instead of they don't have the control to eat it, and because they can't communicate that maybe they're eating too fast or they're choking, it could lead to that. So pneumonia amongst individuals with a developmental disability. In our community, pneumonia is the second most common reason for death. It affects 10% of our population. The first reason is heart failure, and that affects 15% of the population. But it also is results in 17% of unscheduled hospitalizations. And as we were talking about earlier, this is because there's a lot of swallowing difficulties, which is called dysphagia. And that's because there's sensory or motor control problems. There's also behavioral issues, such as eating very quickly or overstuffing the mouth. That leads to that. Disorders of the esophagus, pica engagement, which means eating objects that shouldn't be eaten, often causing choking. And then just decreased level of consciousness that we were talking about, unable to move their head or to have a proper gag reflex. And because we've had so many advancements in medicine, we are seeing the life expectancy of individuals with a developmental disability increasing, which is great, but that also means that we're seeing a lot of age-related conditions that are coming on now, such as less mobility, more fractures, and pneumonia because their lungs are becoming weaker. I just wanted to mention that in the U.S., pneumonia is the eighth leading cause of death. So in our population, it's second, but in general population, it's the eighth. So this is more about my study population. That was all the background information. When I was doing the study, we decided to focus on 2013 and 2014 because it would have the most full data. I started this project about a year ago. And we basically pulled all the individuals from our data warehouse that were actively served in 2013 and 2014. That resulted in about more than 73,000 Medicaid numbers and more than 94,000 Social Security numbers. So we took all those numbers and we ran them through the Medicaid system. So from there, we specifically identified individuals in the Medicaid system who had the clinical condition of pneumonia bacterial or pneumonia NEC. And NEC basically stands for not elsewhere classified. It's kind of just the two classifications of pneumonia in the Medicaid system. And that pneumonia had to be acquired in 2013 or 14. And that basically reduced that list of 90,000 people to 5,775 people who had pneumonia in 2013 or 14. And then from there, I used MEY and state death certificate data to identify 161 individuals who had actually died from this pneumonia diagnosis. So that's almost 3% of the people that were diagnosed with pneumonia passed away from it. That's pretty similar to the general population, which it was 5%. I actually think there were some issues in identifying individuals who had died from pneumonia because Medicaid doesn't give you a cause of death. So that's pretty unfortunate because then we had to use the MEY data, and sometimes there can be underreporting, or another reason is like a lot of misclassification. Pneumonia weakens the heart muscles and it leads to heart attacks. So then an individual may actually die from pneumonia, but on their death certificate, it'll say heart failure. So that was an issue. And so when I first was doing this project, I thought 3% of deaths was very small for this sample, but in 2013 and 14, we only had about 1,600 people die total in our population. So that accounted for 10% of the population, which was supported in the data that 10% of the individuals passed away. So I felt more reassured by that. So here are some characteristics of the study population. I'm not going to get too into detail. I just want to say that I ended up doing the analysis twice because the first time I did it, I had age as a categorical variable of children, middle age, and elderly. But then after I did that, I realized that although a lot of children are diagnosed with pneumonia, very few of them actually die from it. So we only had 4 pneumonia deaths amongst children, even though they made up 32% of the sample that actually got pneumonia. So that was skewing my results. So I reran it, and this time I did it continuous, not categorical, and that's how I got the mean average. And we saw that individuals who actually died from pneumonia were on average 20 years older than the individuals that didn't die from pneumonia. And all of these were statistically significant results that we found, and I'm going to get more into detail in the next slide. But basically, everything except age was categorical, so it was yes, no. They either had a profound intellectual disability or they didn't. They either had Down syndrome or they didn't. They either lived in ICF or they didn't. So these were all the predictors that I tested. I tested sex, age at death, vaccination status, involvement in a day program, having a severe or profound intellectual disability, living in an ICF, how large their living arrangement was. And then I also wanted to see if having cerebral palsy, epilepsy, or Down syndrome also were considered predictors, because in the literature I saw those 3 as commonly associated with having pneumonia. And the ones in red were the ones that I found to actually be statistically significant predictors. So here's a table of that. So if it's a number larger than 1, then it's a positive predictor, and if it's smaller than 1, it's a negative. So as you can see, the vaccine and participating in day service were actually preventative. So an individual who has a pneumonia vaccine has 0.6 times the odds of dying from their pneumonia as someone that does not have the vaccine. And same with the service. Somebody that participates in a day service has 0.47 times the odds of dying, so less odds, as someone that does not. That being said, you can see that the odds ratio for sex is a lot higher. And for that, I indicated females as being 1. So that means that a female has 2.56 times the odds of dying from pneumonia as her male counterpart. And then an individual with Down syndrome has 2.1 times the odds of dying, and the profound severe intellectual disability is also higher odds. So some reasons for that: vaccination, that supported what I thought it would. A lot of the literature said that an individual that has is vaccinated against pneumonia is going to have, they may get pneumonia, but it's going to be less severe and less likely of death occurring because of it. The intellectual disability having a higher odds, that could be because of swallowing difficulties that may arise from it, from having this disability. And there are a bunch of intellectual disabilities that are known to co-occur with developmental disabilities. So those could be autism, cerebral palsy, Down syndrome, fetal alcohol syndrome. Again, that might be a correlation as well. And then Down syndrome. So a lot of literature does support that individuals with Down syndrome are more likely to get pneumonia because they have tongue thrusting issues, which make eating difficult. And then they're also mouth breathers. So that could affect it. And there was a study that showed that 34% of individuals with autism get pneumonia at least once, and 18% get it twice, more than once in their life. So this kind of made me curious about our actual population, and I started looking at the numbers comparing our individuals versus the U.S. general population, especially when it comes to the elderly. So in the DD population, only 3.7% of the population are elderly, compared 10% of the general population. So although we said individuals with a developmental disability are living longer, it's still not as comparable to the general population. They're still living shorter lives. And that could also be the effect, because there are less of them are being affected by pneumonia. In the general population, 85% of the population is being affected by pneumonia and dying from it. In ours, it was only 31% of the elderly that were dying from it. So it could be that the individuals that are a lot sicker are dying earlier, and those are the ones that are getting pneumonia at younger ages. And then something else that was pretty surprising is that we found women are at higher risk of pneumonia. When I was doing the literature review, they're saying that men are at higher risk because they have a different immune system than women that makes them more susceptible to pneumonia, and they also participate in higher risk, less likely to go to the physician once they start getting symptoms. But in our population, I saw that it was actually women dying from pneumonia. So I started looking into that. I don't know, this would require more study, but only 38% of our population in general is made of women, but usually in the general population, it's almost 50-50. So I'm not sure if less women are born with developmental disabilities. That would be something to look into. And then an offset to that would be that of the elderly, less women are older. So we have a lot more elderly men than elderly women, and that's kind of opposite of the general population. Women usually live longer, so there's a lot more elderly women in America than there are elderly men. So there was a difference between the 49% and the 56%, and I'm not sure if that's because the women are dying off earlier or because there were just not enough women to start with. So that would be something interesting to look at. I also tested I tested several interaction terms. The only one that came back significant was the interaction between sex and age. I thought that living in an ICF would really influence a lot of the other predictors because size, participation day programs, I thought individuals who are in ICF were more maybe sicker, but I really didn't see an association between that. So that was unexpected. But I did see an association, an interaction between sex and age. So it's kind of confusing. That's why I put it into numbers. I compared a 20-year-old woman and a 20-year-old man, and I compared a 90-year-old woman and a 90-year-old man. And the odds of a 20-year-old woman dying versus a 20-year-old man are 2.45 times compared to a 90-year-old woman to a 90-year-old man, which is 11.44 times. So basically, older women die more than older men versus younger. So there is an effect of sex on pneumonia death, but it's relative to age as well. So you have to consider both an individual's age and sex when thinking about their likelihood of dying from pneumonia. So this is just a general conclusion of all the predictors that are associated with an individual that is high risk of dying. So a woman who has a developmental disability, who is of older age, does not have a pneumonia vaccination, does not participate in DODB day service programs, has Down syndrome, and a severe or profound intellectual disability, has a higher risk of dying from pneumonia. So this is just like putting it all together. If an individual has all of these characteristics, she's more likely to die from pneumonia. Some things going off of that, participating in day programs, I kind of think that might have a healthy person effect, because an individual that's more healthy is able to participate in these programs versus an individual that is not healthy. so that may skew it. And then also, I showed you earlier that I tried to test a bunch of diagnoses. I had epilepsy, cerebral palsy, and Down syndrome. But only Down syndrome was found to be significant. And I think it may have an actual significance to it, but it could also be from the way that we collect our data. Down syndrome may be better recognized and more often diagnosed or clicked when checking all of the boxes. So we might show, it's not that we're seeing a higher rates of Down syndrome, but we're seeing lower rates of all the other ones that I was talking about. Somebody that has pica or seizures, a county worker who's filling in their records may not at that moment recognize it, or it may come and go. So they might not check the box, and that's why we have lower frequencies of those individuals in our population. So Down syndrome was on there, but I am thinking that others may be associated with it that we didn't find. So some strengths and limitations to this study. It was a really large study sample, almost 5,000 people, which is really great that you can pull a lot of conclusions from. But that being said, we didn't have, only 3% of those individuals passed away. And something that, if I had to redo this, I would take out the children from this study, because like we said, there were 32% of the study were children, but only 4 of them died. So although they were in the original study sample, they didn't really have the outcome that we were looking for. So they kind of just inflated the results. So I would just study adults next time. And when we were pulling this data, I used Medicaid billing, which was really great because they have very good records of diagnoses and the procedures that are done. So I really think that the number of individuals diagnosed with pneumonia was pretty good. But like I was saying earlier, I don't think the death records were as good. So I think we saw less deaths than there really were in the population. And like we were saying earlier, there might have been misclassification. Misclassification in both the diagnosis and the profound intellectual disability. That's something that I decided to only focus on the profound because that's the one that is most often clicked. Sometimes the other ones are not clicked at all. And we have this this problem that no disability and someone did not click the button are the same. So that also may influence the data. So general impacts. If a physician knows what predictors are associated with pneumonia deaths, if an individual comes to them and they have pneumonia, maybe they can act quicker or more aggressively to treat that individual. So it would help healthcare professionals identify these patients and then ultimately decrease the number of individuals that are dying from it. And also awareness, like we said, the vaccination is really the only one of these predictors that you can change. Like you can't change if you were born male or female or what disability you have, but if you can get a vaccine and that can be preventative, this could support that. And also just, we were saying earlier that following someone's health management plan, an individual with developmental disability can go a long way in someone not choking. So maybe if the staff knows that something that simple could save this individual's life, they're more cautious when feeding an individual. And I think that's it. Thank you. Does anyone have any questions? Yeah.
Great. In the beginning, you started off talking about poor nutrition and sedentary lifestyle causing secondary conditions. And I know you mentioned respiratory issues. What were the other conditions that they needed?
Yeah, the other ones, cardiovascular disease, osteoporosis, dental problems. A lot of these individuals have issues with their teeth as well, which makes it harder for them to chew the food and leads to choking, and thyroid disease.
How do you diagnose pneumonia?
So I was saying earlier that pneumonia, usually they catch it because of the symptoms, a lot of heavy coughing, mucus coming out, coughing that lasts several days and gets worse at night. And then when you go to the physician, they check using an x-ray. But during my defense, they're saying how that can be difficult to diagnose. So sometimes you kind of have to take the risk and look at this individual general and say, is it better to start treating for pneumonia even though we don't have the exact test to say they have it or not? Because we said starting treatment early is important. So, and then I think you can also test for actual virus and bacteria in their lungs.
You mentioned that children don't usually die. I was wondering if you use that as a predictor. Children who have contracted pneumonia, they eventually, are those some of the people that eventually die?
I was actually reading today that when you get pneumonia, it kind of destroys the lungs, and it does cause you more likely to have pneumonia at older age. I didn't study it in this one, but it would be very interesting to know. And then for elderly and adults that have pneumonia, it really impacts their breathing and life afterwards because they can never go back to how it was before. So, go ahead, Laura.
Can you go back to your predictors?
Yeah. It's a little slow.
And I'll ask you the other question.
Okay.
So for the pneumonia vaccine, like you said, it's difficult to get to the doctor, so they just go like once a year, if that. So can you get the pneumonia vaccine if you go in like April, even though cold and flu season really isn't until fall? Like physicians could, like a best practice might be that physicians give you that vaccine early in the year just because you're unlikely to make it back or to go somewhere else where you might get it.
The pneumonia vaccine, I think, can be given any time of the year. And as an adult, you only need 1 dose of it. Children get it 2 or 3. So that one, the difficulties with that is bad medical records. You go from one physician to another, one person may have given you the vaccine, and then you go to another one, they ask, oh, have you ever gotten the pneumonia vaccine? And you're not 100% sure. I'm not sure if you can give someone a vaccine twice, if there's any harm to it. That would be interesting to look at. Once ever in your whole life. Yeah. So that's why it's such a simple thing, and they really recommend it for elderly individuals. Once you hit 65, your doctor should be asking you, have you ever gotten the pneumonia vaccine? And then individuals with developmental disability, they should not be waiting until they're 65 because they're high-risk population. Did you have something about?
Yeah, actually, it was the one before. My question was, you talked about the different ICF, the different living arrangement sizes.
Yeah, those I got from our classification of living arrangements, just the smaller than 7, 7 to 15, and 16 plus. I saw that individuals who lived in smaller groups were more likely to survive, but still a lot likelier to get pneumonia in general. But that could be leading back to an individual who lives by themselves or with their family would be grouped into that smaller group. And then the ones that live 7 to 15, that could be somebody that lives in an ICF or a DC, and I was saying those by mandate, they're supposed to have their vaccines and their checks. And I assume, I'm not sure, but individuals with these disabilities, maybe they have more better records of their health. I don't know how often they go from doctor to doctor as someone in the general population would.
So this supports what you were saying about being surprised surprised about the effect of living arrangement. So if you live at home, your family, you might get pneumonia, but you're more likely to survive because maybe you're healthier to be living in the community.
Yeah.
But if you're in an ICF and you get it, you are more likely to die.
Die from
you're
it.
less likely to get it in the first place because you probably got that vaccine.
So the ICF one is tricky. It's what I was saying, that I thought there was going to be lots of interactions because individuals who live in ICF are usually sicker to begin with, but they do have the vaccine as well. So maybe I would want to test to see ICF and vaccination together, and if there's any way to check actual health status, that would be interesting as well. But yeah, the characteristics of the study population pretty well supported the odds ratios that I came up with, the significant odds ratios. Yeah. Unfortunately, we don't have that in our records. I'm not sure if, I can look into Medicaid, but I'm not sure how accurate that would be in Medicaid either.
First of all, I think you did a tremendous job.
Thank you.
Be a part of the follow-up. The more I listened to you, the more I got good information, and the more and more questions popped up in my mind. But so when you were looking at the Medicaid data and then looking at the MUI death data, did you find that aspiration pneumonia was hard to clarify? Because when we're looking at deaths, obviously pneumonia, second word is death, certainly. But sometimes differentiating pneumonia and aspiration pneumonia in the record and trying to get the information is a challenge. You find that?
Yeah. When I first started this project, I wanted to actually look at the type of pneumonia, but it became so complex because unfortunately a lot of these patients, they get pneumonia over and over and over. Even in a year, they can get several pneumonia cases. So then I wasn't sure which one do you choose as the one. So that's why I ended up taking out pneumonia type and just looking, did the person have pneumonia or didn't? But it would be interesting to just pool, instead of comparing the different types, just to pool everyone that had aspiration pneumonia and see the characteristics of that population.
I think that'd be terrific because to me, aspiration pneumonia is the one that's most preventable, right? We really know that. And I know some folks get viral or bacterial pneumonia over and over again too, and trying to really know what was the true cause.
Yeah.
I tell you what, you did a terrific job, and it's something that we continue to need to get more and more information about because it really impacts our population more than the general population. It
does, and doing this project, it just like opened up so many cans of worms. I was just like, what about this? What about that? And the more I present it and people are asking questions, the more things that could be researched. I was actually reading today a website that was like pro pneumonia knowledge, and they were saying that this isn't a field that is being studied as much as it should be. It's affecting the general population so much. We're saying it's one of the leading causes of hospitalization, but people are not researching it. There's no like going on a run for pneumonia. There's no banner. This is, and especially we have antibiotic resistance. Pneumonia is becoming harder to treat, and it's kind of just going to the side. So.
Well, I think there's an expectation that, well, if somebody gets pneumonia, you know, it's different than sometimes cancer or heart disease or something else where people really focus on it.
Yeah. But this is, compared to cancer, pneumonia is a lot easier to treat and prevent. So, yeah, Hope.
You might not know the answer to this, but I was just sitting here thinking about, we tell people to get the one pneumonia shot, and you get it when you get older. But when we look at this, obviously our people with weakened immune system, they shouldn't wait till they're 65 to get it. They should get it younger. And we're learning now about some other vaccinations that you're supposed to have only gotten once in your life, and now they're saying you need a booster later. And I'm wondering, have you read anything about whether they're saying if you do have your first pneumonia shot when you're in your 30s or 40s, if you do need a booster when you're older?
I didn't read any booster ones. I saw for children, if you're a child and you're very susceptible to it, it takes 2 or 3 shots, but they're all very close together. So I think those are kind of boosters. Maybe you can't give a full dose. For adults, it was just saying 1, and I didn't see any booster. But I would be interested to see if getting the vaccine more than once is harmful, because I'd rather be just like cautious and get it twice than not ever have had it. So that
We always really work hard to support the flu shot as well. I mean, we have alerts that we put out that talk about get the pneumonia vaccination, get the flu shot. You know, there's no question, majority of the folks we serve are at-risk population.
Yeah.
Do you have any ideas about physician education? Because I know there are some programs that really offer videos and online credits for physicians on working with people with developmental disabilities, but it's not very prevalent. And that certainly is critical to our people getting better care. Do you have any recommendations, or were there any things that came across in your studies that speak to about that?
The only thing I would think of is to make it one of the, so there's continuing education programs that physicians have to do, and I'm not even sure if this is an option for that. Like having this special population be one of the credits that you can do throughout your career. And then also maybe introducing special populations in medical school. I think that's something that they don't do, and they should. Like not just individuals with developmental disabilities, but maybe a whole course for special populations that you're going to meet throughout your career. Even get someone's mind like thinking about it.
Is this data available to be published anywhere? I mean, like if we wanted to share it as part of an alert or anything.
I guess.
Yeah, we definitely
Mhm.
your analysis to do with. I think before, so you should know, everyone, that Armene has graduated, and like she's mentioned, she's going off to medical school. So we really only have another month or so that she's going to be here. But maybe she can put this together into sort of a brief.
Oh, part of the data.
Type thing. You know, so that it's more. This is lots of information and academic and wonderful. But I think for something sharing, maybe we could condense it down to sort of a one-page highlight kind of thing.
I know that we talked to our mortality review board about your study, and so Dr. Stratford, one of our physicians, was really interested in your analysis. So yeah, anything that we can present back.
I even have, the data is very clean and it's de-identified, so I don't know how it goes about sharing that data, but it is like everything is coded and ready. I was even thinking taking out the children would not be that difficult, because you would just filter out the children and then rerun the analysis on it. So, but I can definitely work on a data brief with the data. Yeah.
I think you did a nice job telling the story at the beginning and then wrapping it up. And I know the communications team has been taking recorded webinars like this and then splicing together different like little 1-minute sections so that people actually watch it. Maybe that would be, that's something I would click on if I saw it on the YouTube, on the DOD YouTube channel.
Neil, do you have a question?
Yeah, I was wondering if there is a way to measure how severe or how sick someone is when they receive treatment. And the reason I was thinking about this was looking at the odds ratio and seeing how low it was for people who are in adult day services. And I was thinking, well, maybe if they're going, one, they could be healthier, like you said, but I was thinking maybe if they are sick, there's someone there who can spot it much sooner.
Yeah, for sure. That was something that came up a lot during my poster presentation, just that they are staffed with nurses and individuals who are very used to working with individuals with disabilities. So you might be quicker to notice a change versus a parent that, like, it's hard to know if this is just a cough that's going to go on away on its own, or if you should be very concerned. So those day services, it was really interesting to think about that as well.
I think it's similar with the ICF. I was thinking the very same thing, because typically people there, you would expect to be more medically involved, but you'd also expect that if everything's monitored so closely that the minute something happens, they're going to be right on it. So you wonder if that doesn't, there's not kind of a wash, as opposed to somebody who's at home, who has a really attentive mom or dad or brother or sister, or just doesn't go to the doctor at all. So, yeah.
Something that one of the data briefs I was making earlier for cancer, I found that there's a bunch of videos made. It's a series of individuals with developmental disabilities talking about going to the doctor and encouraging others to go to the doctor. And this one was specifically focused on going and getting a cancer screening. So women were talking about like, oh, I went and got a mammogram. It wasn't that bad, you know? And I was thinking, I don't know where they broadcast those, but if they could make one that said, like, have you had your pneumonia vaccine? Like, I was sick once and I had this horrible cough and I don't want you to get sick. Things like that might be helpful too. So
I think as we have more and more people who are not living in an institution and also not living with their mom or dad, you know, people that are living in the community and making lots of their own personal life decisions, one of those things is about their health care. And there's not a lot of information about pneumonia vaccinations or cancer screenings or any of that kind of thing that is targeted to the adults that we serve.
I even saw these very large and beautiful posters that show an individual with developmental disability and all the vaccines and screenings they're supposed to get made appropriate for their, because it's different from the general population. It was meant for physicians that work with individuals with disabilities to print it out and put it big, either in the waiting room or in the actual, in the patient room, so that patients can look at it and become more interested, and it can be a reminder for the doctor to ask about these screenings as well. So that was interesting. Yeah.
Does the data you're working with have like demographic information? Because I wonder if looking at, you know, like income, race, geography, that type of stuff might kind of help inform some of the questions about like the various
Income we don't have. Race we do have, but I'm not sure how great that would be. I'm not sure, does Medicaid? Maybe Medicaid might have race as well. But we definitely don't have income. But it would be interesting to look at some of these demographics.
I think at your defense, we talked a little bit about regions of the state and whether or not living in proximity to a hospital system or something increased your likelihood of being diagnosed early or something like that.
We do have like metropolitan living and those classifications we could look at as well. Anything else? Okay. Well, thank you very much, everyone.
Terrific job.
Even more of